Well, we've only got a few minutes left. Maybe for this last bit, we can talk about what other therapies are out there, emerging, soon to be experimental. What are you really excited about, Vamsi?
You know, I think this idea of reducing inflammation is, you know, this word inflammation has been utilized since the 80s of trying to target atherosclerosis as an inflammatory marker. And, you know, there's a trial called CANTOS that was published in 2017, I believe. It was anti-interleukin 1LB, and it had, I believe, a 25% reduction in MACE outcomes.
Something 15%.
Oh, 15% okay.
Overall, but yeah.
15% overall.
If you look in patients that had CRP reductions, and the benefits were much, much larger.
Right. So if it actually reduced the CRP, that there was benefit. So I think this, the age of having monoclonal antibodies and going after interleukins and TNF, this seems to be going back to your point of the, you know, the physiology isn't as simple as when we learn in medical, like if you block this, this outcome will be happening. It's much more complex. And now we're getting targeting therapy like PCSK9s, when we're trying to eliminate or decrease our side effects but also targeting a multimodality approach. And I think as an interventional endovascular person, it's exciting when, you know, it's fun when we treat someone, but it's really, really fun when we treat them and we never have to see them again back in the hospital for 10, 15 years. It's very gratifying that we really have helped change their life. And so I think the process right now to go after inflammation is very exciting. And then the second thing I'm really excited about is also this machine-based learning and artificial intelligence. I've had the ability to kind of see some of the infancy on this for what it can do to systems, because I think when we're dealing with chronic conditions that have residual risk, identifying that still is a major problem, and that not everyone is equipped to do so, even though it should be as easy as it is. And I think identifying those high-risk patients immediately in a healthcare system and automatically kind of having system approach to treat those patients can help really reduce, you know, the healthcare costs. Because right now, cardiovascular disease is costing $555 billion, and they project it's going to be $1.1 trillion in 2030. So there's no way we can sustain this pace. And so I think having these amazing therapies, but being able to target it is going to be awesome.
Yeah, no, that's a great couple of things. What do you think is hot and next?
I think the most interesting thing in cardiovascular medicine right now, in my mind, is we are now in the age of having not only personalization. You know, I was a poo-pooer of the genetics of cardiovascular disease and the transcription into biology, but at the American Heart Association meetings and others, what we're starting to see is that molecules, so we've always thought, oh, there's a protein, block the protein blocks the receptor, that's how stuff works, that works well. We give it to people, we say, please take it every day, please really take it every day. But the idea that you might inhibit the transcription of an RNA molecule into that protein, and you could do a shot twice a year for inclisiran is one of these agents that's being studied for LDL lowering, but there's also epigenomic modifiers. There's other targets now where we are going to get to the age and have the financial conversation about what if I did say, instead of just coming in for your flu shot, I'm going to give you a shot, and you're going to come in twice a year, and I'm going to get your LDL down to 30, and you're not going to take a pill. Right. How many people are going to line up at the CVS for that? And that's going to be a really transformative thing that we're going to really rely on our primary care physicians to help us take care of it. So I think we have to see those data, but if you said to me in 5 years what's going to be really exciting is that we're going to know a lot more specific risk for our patients, and we're going to be much more specific about our therapy.
So inflammation, AI, personalized medicine, genetics, they took all the easy stuff.
Yes, well,
what's next? What do you think is exciting?
You know, I think what's still incredibly exciting, no biases on my part, is optimizing antithrombotic therapy. And I've heard it said, you know, we've come to the end of the road and we've had so many therapies now let's move to other things. But I think nothing could be further from the truth. I think there are at least 3 ways we can optimize antithrombotic therapy. One is we got to continue to seek the sweet spot with our dosing. And when I say dosing, that may be combination of treatments. Like Compass has shown us hitting that sweet spot, and suddenly we've got a benefit where in the past, warfarin plus aspirin produced no benefit. I think the second is targeting the right pathway. So the story about the contact pathway, if we could target that selectively, not only might we prevent valve-related, mechanical valve-related thrombosis, but by stopping this amplification pathway, we could achieve greater efficacy with lesser bleeding risk. And then the third, I think, is the upstream targeting of drivers of thrombogenesis. And you've touched on one, inflammation, incredibly exciting, but there are other things. There are nets, there are these complexes floating about the circulation with neutrophils and strands of genetic material and platelets. Are intriguing story, these little monsters going around and firing up coagulation. And then recently a paper on CHIP, clonal hemopoiesis of indeterminate potential. I mean, how exciting is that? So we have these little pieces of errant DNA causing trouble. So cardiovascular medicine is incredibly exciting, and there's so much more that we're going to achieve in the years to come.
Well, those were really three great answers. Hopefully this session has been useful to the audience in terms of what you can do practically, but also a little bit of a glimpse into the future. Those were really wonderful futuristic types of answers. So thank you all for your contributions to this discussion. You've been a great faculty. And on behalf of our panel, we thank you at home for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thank you very much.